Welcome. Today we shall be looking at deep vein thrombosis. A deep vein thrombosis refers to a formation of a thrombus or a blood clot in a deep vein that is most commonly in the lower extremities. When inflammation of the vessel accompanies the thrombus, the condition is termed as deep vein thrombophlebitis. While deep vein thrombosis can occur without overt inflammation, thrombophlebitis implies a combined pathological process of clotting and inflammation. Clinically, the most common signs of deep vein thrombosis include a unilateral calf or groin pain and tenderness, often accompanied by swelling. The affected area may be warm and tender to touch, and a positive Homan sign, which is a calf pain elicited during dorsiflexion of the foot, may be present. Although this finding lacks specificity and should not be used as an isolation for diagnosis. In the pathogenesis of deep vein thrombosis, Virchow's triad describes the three primary factors that contribute to the thrombus formation. There's a venous stasis, endothelial injury, and hypercoagulability state. A venous stasis may result from immobility, heart failure, or obesity. An endothelial injury can result due to a trauma, surgery, or a central venous catheterization. Hypercoagulability may be inherited, such as in factor V laden mutation, or acquired settings such as malignancy or cancers, pregnancy, or hormonotherapy. Understanding the risk factors for deep vein thrombosis is vital for both prevention and clinical suspicion. These risk factors include a recent surgery, trauma or a fracture, prolonged immobilization, for example during flights and bed rest, cancers or malignancy, hormonotherapy, pregnancy, obesity, smoking, and genetic thrombophilia, for example protein C and S deficiency and antithrombin 3 deficiency. DVT often presents subtly, and patients may exhibit unilateral leg swelling, calf pain or heaviness, warmth, and arrhythmia. In some cases, symptoms are minimal or absent, making a high index of clinical suspicion essential, particularly in at-risk individuals. Remember that signs may mimic cellulitis, muscle strain, or a ruptured Baker's cyst. The diagnostic evaluation of deep vein thrombosis. Initial clinical assessment involves conduction of a Wells score, which is a validated tool to stratify patients based on their DVT risk. If the risk is low and a D dimer is negative, DVT can often be ruled out. A positive D dimer supports a possibility of a clot formation, but is non-specific. A duplex ultrasonography is the first-line imaging modality due to its non-invasiveness and high sensitivity. If proximal or pelvic deep venous thrombosis is suspected and an ultrasound is inconclusive, you need to consider a CT scan or a magnetic resonance venography. A traditional contrast venography remains the gold standard but is now rarely used due to its invasiveness. Regarding the management, anticoagulation is the cornerstone of deep venous thrombosis treatment, where we use a low molecular weight heparin such as enoxaparin. A direct oral anticoagulants like rivaroxaban and apixaban are increasingly preferred due to the ease of administration. In patients stabilized on heparin, and warfarin may be introduced with an overlap. For select patients with extensive thrombosis or hemodynamic instability, thrombolytic therapy may be considered. An IVC filter is indicated when anticoagulation is contraindicated, for example in patients who are having active bleeding. And some of the supportive nursing intervention focuses on preventing clot extension and embolization. You need to elevate the affected limb above the heart level to promote venous return. Avoid using knee gauge or placing pillows under the knees to reduce the venous stasis. You should never massage the limb due to the risk of dislodging the clot, and apply anti-embolism stockings to assist in venous return by ensuring that patients are taught on the correct way to use these stockings. Use a warm, moist compress to relieve discomfort and to regularly monitor calf circumference and local warmth. You need as well to monitor for signs of pulmonary embolism such as dyspnea, chest pain, or hemoptysis, which are basically medical emergencies. Pharmacologically, you need to administer anticoagulants as prescribed, and during heparin therapy, you need to monitor activated partial thromboplastin time to maintain a therapeutic range. When transitioning to warfarin, monitor prothrombin time and international normalized ratio as well. Educate these patients about bleeding risks, the signs of over anticoagulation, and the importance of medication adherence. Monitor for any bruising and hematuria, as well as gastrointestinal bleeding. Patients' education plays a vital role in preventing recurrence of deep venous thrombosis. Teach these clans to recognize the signs of bleeding and importance of regular lab monitoring. Emphasize on avoiding prolonged sitting or standing, crossing the legs, or wearing tight garments, and recommend leg elevation with a structured walking program to promote circulation. You need to reinforce the importance of follow-up appointments and the use of medical alert identification and avoiding an unprescribed medication. Strongly advise smoking cessation and lifestyle modification as part of the comprehensive risk reduction.